Hello everyone and welcome to our module on postpartum. Let's start by talking about postpartum hemorrhage. So most deliveries are associated with some blood loss, but postpartum hemorrhage refers to significant blood loss, and it's a potentially life-threatening complication of pregnancy and delivery of a baby. There are a couple of formal definitions of postpartum hemorrhage. The first one is based on the volume of blood loss. By this definition, postpartum hemorrhage is the loss of more than 500 cc's of blood in a vaginal delivery or more than 1,000 cc's of blood in a cesarean delivery. The other definition of postpartum hemorrhage is any postpartum bleeding with evidence of hypovolemia that develops within 24 hours of birth. And as I said, postpartum hemorrhage is potentially life-threatening. It can lead to shock in the mother. It can also lead to a rare complication of the pituitary gland called Sheehan syndrome, which we'll talk about later. And there are some general measures for treating postpartum hemorrhage due to any cause, but you should be aware that the treatment varies significantly based on the underlying cause. So lots of the management of postpartum hemorrhage is aimed at identifying the underlying cause and then applying a specific treatment for that cause. There are, however, some general treatments that can be used in all causes of postpartum hemorrhage. First of all women with postpartum bleeding should receive intravenous fluids, and transfusions are used when there's significant blood loss. And then in cases of severe postpartum hemorrhage due to any cause, there are a number of high-level interventions that can be employed. One is called intrauterine balloon tamponade, which involves inserting a balloon into the uterus and inflating it to try and stop the bleeding. If you can identify the artery that is bleeding through an angiogram, you can embolize it to try and stop the bleeding. Hysterectomy is sometimes done in cases of severe postpartum hemorrhage that can't be controlled. And then there is a drug called tranexamic acid, which is an antifibrinolytic drug. Basically, it promotes the formation of blood clots, and this is also sometimes used in cases of severe postpartum hemorrhage. The four major causes of postpartum hemorrhage are shown on this slide. The most common cause is uterine atony, which we'll talk about in a minute. You can also have postpartum bleeding from GU trauma, especially cervical lacerations. Women with coagulopathy can bleed postpartum, and there can also be postpartum hemorrhage if there are retained placenta or membranes. And we'll talk about all four of these causes in the next few slides. So after delivery, the uterus normally contracts, and this constricts spiral arteries in the uterus to stop the bleeding in the postpartum state. But if there's lack of contraction, that's called atony, and that leads to uterine bleeding and postpartum hemorrhage. The risk of this complication is increased in certain situations. First of all, when there's excessive uterine enlargement during pregnancy, that raises the risk of uterine atony. So for example, if there's macrosomia or a multiple gestation pregnancy, that makes this complication more likely. When labor is abnormal, for example, if it's prolonged or if there's lots of oxytocin required for labor and delivery, that raises the risk of uterine atony. And then lastly, if there's anything that blocks normal uterine contractions after delivery of the baby, this makes it more likely that bleeding will occur. So this can be seen in women who have fibroids. It can also be seen in women who are administered magnesium sulfate as part of the management of preeclampsia during labor and delivery. For women with postpartum bleeding from uterine atony, the first-line treatments are oxytocin and uterine massage. Oxytocin causes the uterus to contract, and this can limit the bleeding. You can also manually stimulate the uterus to contract by massaging it with your hands. If there's ongoing bleeding despite these interventions, additional so-called uterotonic therapies can be required. All of these therapies cause the uterus to contract. The first one is methyl-ergonovine. The downside of this drug is it can raise the blood pressure, so it's contraindicated in women who have any history of hypertension. Another option is carbaprost. Carbaprost is a prostaglandin analog. The downside of this drug is it can cause bronchoconstriction, so it's contraindicated in women who have asthma. And then another option is misoprostol. This is also a prostaglandin analog, but it doesn't cause problems of hypertension or asthma, so it can be used when one of the other drugs is contraindicated. And then in severe cases of uterine atony, some of those high-level interventions I mentioned before are sometimes necessary, things like balloon tamponade, embolization, or rarely hysterectomy. Genitourinary trauma is another cause of postpartum hemorrhage. Lacerations to the lower GU tract during delivery of the baby can lead to bleeding. In particular, lacerations of the cervix are especially difficult to access and treat, and they tend to bleed more and often cause more postpartum hemorrhage. GU trauma is more common if the delivery of the baby was difficult. For example, if there was macrosomia, if instruments had to be used for an operative delivery, if there was a breech extraction, or if there was precipitous labor. This refers to birth that occurs within 3 hours of contractions. And the treatment of GU trauma is with manual pressure on the bleeding areas of the GU tract and surgical repair. Coagulopathy is another cause of postpartum hemorrhage that always has to be considered. So as you may know, in pregnancy, women produce lots of clotting factors, and therefore pregnancy is a hypercoagulable state. But pregnancy is also a state in which clotting factors are constantly being consumed. So you can think of pregnancy as a state of chronically compensated DIC. Basically, women who are pregnant are always in a low-grade form of DIC, where they're making lots of clotting factors and they're hypercoagulable, but they're also prone to bleeding from consumption of clotting factors. So because of this, it takes a small amount of hemorrhage to cause clinical evidence of DIC, including coagulopathy and bleeding. So after delivery, the blood loss associated with delivery can consume clotting factors, and that can cause women to become coagulopathic. So in any woman who is postpartum with prolonged bleeding, you have to test for coagulopathy. The testing that's usually done is CBC with a platelet count and measurement of the coag times, including PT, PTT, and INR. The last major cause of postpartum hemorrhage is retained placenta. So normally the placenta is expelled by uterine contractions after delivery of the baby. But if placental tissue or other tissue is retained, this can lead to postpartum hemorrhage and bleeding. This can happen with any pregnancy, including pregnancies with a normal placenta, but it's especially common in women who have placental problems like placenta accreta, increta, or percreta, and I talk about these in another video. So after delivery of the baby comes delivery of the placenta, and the placenta is always examined to see if there's evidence that pieces of it may have been left behind. If there's placental tissue left behind, you can attempt to separate the retained tissue by curettage. But if this doesn't work, retained placenta leading to significant postpartum hemorrhage often is an indication for a hysterectomy. There is a special subtype of postpartum hemorrhage called late postpartum hemorrhage or secondary postpartum hemorrhage. This refers to bleeding that begins more than 24 hours after delivery, and in this situation there are three major causes of bleeding you have to consider. One of them is retained products of conception. So a retained placenta can start to bleed more than 24 hours after delivery and not cause bleeding immediately in the postpartum state. And then the other causes are endometritis, which we'll talk about later, and also inadequate involution, which we'll also talk about later in this video. But the key point here is that there's a different differential diagnosis for this type of bleeding that occurs late, more than 24 hours after delivery. Sometimes after delivery of the baby, a situation can arise where the uterus turns inside out and the uterine fundus protrudes through the cervix. This is called a uterine inversion. There's a drawing on the screen here of what this can look like, and when this occurs, you can often feel on exam a firm rounded mass protruding from the vagina, and that mass is the fundus of the uterus sticking out. This often leads to severe hemorrhage, and it's a more common problem in women who are multigravidas. It's less common in women who are nulligravidas. And usually this is an iatrogenic problem. It's caused by too much cord traction. So after the baby is delivered, you can tug gently on the umbilical cord to try and get the placenta to come out, but if you pull too hard, you can cause a uterine inversion. The treatment of uterine inversion involves an attempt at manual replacement. Sometimes this can't be done, and so in these cases you can use tocolytic drugs to relax the uterus and make it easier to replace. The drug that's often used is nitroglycerin because it's very rapid acting, although you can use other drugs including terbutaline, and these drugs relax the uterus and make it easier to replace. Once the uterus has been replaced, there's often uterine atony and bleeding, and so after replacement, often oxytocin is required as therapy to stop the uterine bleeding. Sheehan syndrome is a rare complication of postpartum hemorrhage related to the pituitary gland. The idea behind Sheehan syndrome is that the pituitary gland normally enlarges in pregnancy, and this makes it vulnerable to infarction if hypovolemic shock occurs. So rarely women who have postpartum hemorrhage can infarct the pituitary gland, and that can lead to clinical features of hypopituitarism. This can present with clinical features from loss of any of the pituitary hormones, but one thing that you can see in women who are postpartum is failure to lactate, and that's from loss of prolactin from the pituitary gland. You can also see things like amenorrhea or loss of pubic hair from loss of gonadotropins. There can also be weight loss from central hypothyroidism. The diagnosis is made through hormone testing to identify hypopituitarism and then an MRI of the head. There are a number of radiology findings by MRI early on in Sheehan syndrome, but eventually the cella turcica becomes empty and looks black like what's shown here in this picture. And the treatment for Sheehan syndrome is with hormone replacement, similar to the treatment for other causes of panhypopituitarism. Let's talk about amniotic fluid embolism, which is a rare complication of pregnancy that usually occurs during labor or shortly after within about 30 minutes. The cause of amniotic fluid embolism is amniotic fluid or fetal cells or fetal debris that enter the maternal circulation, and they circulate throughout the body and cause a diffuse inflammatory reaction. This is unfortunately often a fatal complication of pregnancy. The treatment is with supportive care only. There is no reversal agent or cure. The clinical features of amniotic fluid embolism can be divided into two phases. Initially, women develop the respiratory and shock phase. The dominant clinical features here are respiratory distress and hypoxemia and hypotension and shock. This is shortly thereafter followed by a second phase called the hemorrhagic phase, where there's massive hemorrhage related to DIC. And then seizures also commonly occur. And so when these things happen, you can make a clinical diagnosis of amniotic fluid embolism, and you simply have to support the woman with mechanical ventilation and transfusions and hope that she's able to survive the amniotic fluid embolism. Let's talk about some routine postpartum care issues. You should be aware that transient low-grade fevers are normal in the first 24 hours after delivery. And we'll talk more about this when we talk about postpartum fever in just a minute. It's also common for women to develop shivering and chills after delivering a baby. This occurs in up to 50% of women. The breasts become engorged after delivery. They can become firm, and some women will note fullness, pain, or tenderness of the breasts after delivering a baby. And then you should be aware that self-limited hair loss is common 1 to 5 months after delivering a baby. Usually it's mild and it often goes unnoticed, but some women will ask about this, and you can advise them that this is usually a self-limited process. Uterine involution refers to the uterus returning to its non-pregnant size and state after delivery of the baby. In order for this to happen, the superficial decidua layer has to be shed, and this produces vaginal discharge known as lochia. So lochia is the normal vaginal discharge produced after delivery as part of the process of uterine involution. For the first 3 to 4 days after delivery, the lochia is called lochia rubra. That's because it has a red color and it looks similar to menses. After about day 4 and for up to 2 weeks, the lochia takes on a pinkish brown and watery color. This is called lochia serosa. And then several weeks after delivery, the lochia can become yellow in color. This is called lochia alba. And as I mentioned earlier, abnormal involution called subinvolution is a potential cause of late postpartum bleeding. This refers to inadequate physiologic closure and sloughing of that decidual layer. This can potentially cause late postpartum bleeding, which, as I said before, is beyond 24 hours after delivery. Let's talk about postpartum urinary retention. The definition of postpartum urinary retention is an absence of urination by 6 hours after birth. And one of the common reasons for this is injury to the pudendal nerve, which can happen during delivery of the baby. Usually this improves with time and ambulation of the mother, but it can be treated with intermittent urinary catheterization as needed until normal urinary function returns. Pubic symphysis diastasis is a rare complication of delivery. It refers to separation of the joined pubic bones. This is an x-ray of what it looks like on the screen here. You can see the pubic bones have become separated. This leads to pubic tenderness at the pubic symphysis and pain with ambulation. The diagnosis is made either clinically or with an x-ray like what's shown on the screen here. And the treatment is with analgesia, physical therapy, and sometimes a support truss is required until the pubic bone has time to heal. Next, let's talk about postpartum fever. So as I mentioned before, a low-grade fever is very common in the first 24 hours after birth, especially in women who have delivered via vaginal delivery, and usually this will resolve spontaneously and it doesn't indicate a serious underlying condition or infection. To meet the definition of postpartum fever, the temperature has to be greater than 100.4 for any 2 of the first 10 days postpartum. So when you have a fever that meets these criteria, then the differential diagnosis includes all of these things listed on this slide, and so we'll go through these one at a time in the next few slides. Wound infections that cause postpartum fever are usually related to an abdominal incision done as part of a cesarean delivery. Infection of a genital wound caused by vaginal delivery is incredibly rare. Even deep lacerations in the genital tract with feces in them rarely become infected and cause a postpartum fever. The presentation of a wound infection in a postpartum woman is with swelling and erythema and purulent drainage at the wound site. This is very similar to any post-surgical wound infection. The treatment is to drain the wound of pus, then irrigate it and debride it, plus administer antibiotics. In women who have had a cesarean delivery, wound infections usually develop days 4 to 7, and prophylactic antibiotics are usually given before cesarean delivery to limit the risk of a wound infection. Usually it's a single dose of cefazolin 1 hour before the incision for a cesarean delivery. Urinary tract infections have to be considered in any woman with postpartum fever. They're a common source of persistent fever after delivery. Women who have just delivered a baby can develop cystitis or pyelonephritis, and the diagnosis and treatment is the same as in non-postpartum patients. Lactational mastitis, also called acute mastitis, is a cause of postpartum fever in women during breastfeeding after delivery of their baby. It's caused by trauma to the skin around the nipple, and it leads to breast erythema and tenderness. This is a picture of what it looks like on the screen here. It's very similar to cellulitis in the skin anywhere, but this occurs around the breast related to breastfeeding. Women often have fever and malaise, and most commonly the infection is caused by Staph aureus. The usual treatment is with dicloxacillin or cephalexin. Both of these can usually cover Staph aureus. And importantly, and it's high yield to know this for your boards, the mother should continue nursing. There's no reason she has to stop nursing because she has an infection like this. And in fact, by continuing to nurse, the milk will let down, and this will make the process of nursing easier later on when the infection has resolved. You should also know that in some cases, lactational mastitis can progress to abscess requiring drainage. If the woman is not responding to antibiotics and there is a flocculent mass, you should consider that there may be an abscess there that needs to be drained. Endometritis is another cause of postpartum fever. This refers to infection of the decidua or the endometrium after delivery of the baby. It presents as postpartum fever with tenderness of the uterus and leukocytosis in the mother. There's also often foul-smelling purulent discharge. Endometritis is usually a clinical diagnosis, and most cases are a polymicrobial infection, so they have to be treated with broad-spectrum antibiotics. A regimen that's commonly used is gentamicin and clindamycin, although there are other options. And then it's high yield to remember for your boards that infection of the endometrium rarely leads to toxic shock syndrome. This is an immune-mediated process where the patient develops a skin rash and desquamation of the skin and hypotension, and it's a potentially life-threatening complication of endometritis. Septic pelvic thrombophlebitis is a rare cause of postpartum fever. This refers to venous thrombosis and infection that develops in the ovarian veins or the deep pelvic veins. The thing to know about this condition is that it usually presents as fever, and often that's the only clinical feature. Although there can be abdominal pain because there's infection and thrombosis in the pelvis, that's not always present, so sometimes you only see a fever. Now, in a woman who's just delivered a baby who develops a fever, the diagnosis is often presumed to be endometritis. But if she actually has septic pelvic thrombophlebitis, there'll be a poor response to antibiotic therapy alone. There are two subtypes of septic pelvic thrombophlebitis. The first is the ovarian vein subtype. This usually develops within a week of delivery, and the mother often looks acutely ill with fever and abdominal pain localized to the affected side. The pelvis is often tender to palpation, and a classic finding is a rope-like mass on examination that extends from the uterus to the lateral abdomen, caused by the thrombosed ovarian vein. The other subtype is the deep septic pelvic subtype. This has a more subtle presentation. Patients can have fever, but often they're not acutely ill appearing. Often there is no abdominal or pelvic tenderness. And as I said in the last slide, often these patients are presumed to have endometritis, but they have a poor response to antibiotics. And sometimes in these patients, pelvic imaging is even normal, and the only way you know they have thrombophlebitis is that you treat them with anticoagulants and they get better. So you should suspect this diagnosis in patients who have persistent fever after delivery of the baby despite receiving antibiotics. Often it's a diagnosis of exclusion, and it's proven only by the response in the mother to anticoagulants. You can sometimes make the diagnosis by pelvic imaging with CT or MRI. This is best for identifying the ovarian vein subtype, and importantly, a negative CT or MRI does not exclude that the patient could have septic pelvic thrombophlebitis. The treatment is with antibiotics plus anticoagulation. Broad-spectrum antibiotics are often used, like gentamicin and clindamycin, plus intravenous heparin or low molecular weight heparin. And so in a board question, this is going to be a woman who has a fever and doesn't get better with antibiotics, and then if you add heparin or another anticoagulant, then the fever improves, and that proves the diagnosis of septic pelvic thrombophlebitis. I'll finish this video by talking about postpartum mood disorders. So the most common postpartum mood disorder is the postpartum blues. This occurs in up to 85% of women in some studies. And the postpartum blues include symptoms like depressed mood, insomnia and fatigue, and poor concentration. Usually, however, the symptoms are mild, and they usually start 2 to 3 days after delivery, but they resolve within 2 weeks. And the treatment for the postpartum blues is supportive. Like I said, usually it will resolve within about 2 weeks. Less common is postpartum depression. This occurs in up to 15% of women in some studies. And in postpartum depression, in contrast to postpartum blues, the symptoms will persist beyond 2 weeks. And in addition, the symptoms will meet the DSM criteria for depression, which are all the SIGI-CAPS symptoms. And in postpartum depression, the treatment is with cognitive behavioral therapy or medications like SSRIs. And then the rarest of the postpartum mood disorders is postpartum psychosis, so let's talk about that now. Postpartum psychosis develops in less than 1% of all births, and usually it occurs in a woman who enters pregnancy with a known psychiatric disorder. Most commonly it's bipolar disorder, but it can be other disorders like depression with psychosis or schizophrenia or schizoaffective disorder. And it's especially common if the woman had to stop her meds during pregnancy out of concern for the baby. And usually the symptoms of postpartum psychosis occur within 2 weeks of delivery. The clinical features of postpartum psychosis are similar to other psychotic disorders, so this can include delusions or hallucinations or disorganized thought. The delusions in postpartum psychosis often involve the baby. For example, a new mother who thinks that something is wrong with her baby, even though the baby appears healthy and fine. This could be evidence of a delusion associated with postpartum psychosis. I've listed some of the risk factors on this slide. If there is a personal or family history of postpartum psychosis, then it's more likely it will occur. As I said before, most patients who develop this have a pre-existing psychiatric disorder like bipolar disorder, schizophrenia, or schizoaffective disorder. It's more common in the first pregnancy, and it's more common in women who have to discontinue their psychiatric medications during pregnancy. And then it's super high yield for your boards to know that in women who develop postpartum psychosis, they need to be hospitalized. There's a very high risk of suicide. There's also some risk of harm to the baby. And basically, mothers who develop postpartum psychosis are unable to care for themselves or the baby temporarily, and that's why they need to be hospitalized. The treatment of postpartum psychosis is complex, but it often involves antipsychotic medications and sometimes electroconvulsive therapy. And that concludes our module on postpartum.